Today in our COVID advocacy exchange session, we are focused on outlining our paths to impact and change. We are honored to welcome everybody if it's your first time, or welcome back to many people, if not most of the people with us already today. I am Dave Fuhrer, the CEO of Grit Health. I'm also a two-time cancer survivor, bereaved caregiver for my father, and a real believer in research as the future to change not only survival, but the experience of going through a diagnosis and treatment and survival. In our working groups today, we're going to be talking about the individuals who are most impacted by these areas that we're all focused on, and who are the stakeholders, who are the people that we really need to make sure are involved to not only create, but sustain change. Right, and that's the focus of this program, is really to be a part of the change in tangible and meaningful ways. In just a moment, I get to welcome Dr. Rachel Giles, who will be our opening conversation. And not only do I respect Rachel incredibly for her advocacy expertise, but just as much for her personal experience. And so deeply honored to get to have the conversation with Rachel before we move into our working groups again this month. Here's the emotional part for me. Before we talk about the future of advocacy and where we are today, we really need to and should honor where we've all come from. And I know that every one of us has had people in our lives that we've looked up to, or who have helped us find our voice. They are the legends that came before us. And I had an experience last week. I know, Sarah, you're here with us right now. Sarah emailed me a picture of her and Jack Whelan, and I want to share it with everyone. I don't know if many or any of you know Jack. When I became an advocate in 2012, and then started to work with different organizations and really trying to figure out what my purpose in advocacy was, I got to meet Jack, and he is, in my opinion, the quintessential advocate. He is passionate and genuine and collaborative, and he makes you feel like you can be a part of making the world better. We lost Jack a couple of years ago, and he's one of the individuals that in everything I do, I try to honor and respect Jack's legacy and to be a part of carrying forward the heroes that have all brought us to where we are today. And so if we could, I would love to start, before we move into the keynote, your chat box is at the bottom of the screen. And I would love to know from you, who is a person that has really influenced your life, or who is one of your advocacy heroes? If you want to write their first name, their full name, their nickname, would love to just see in the chat box anybody that's really influenced your life. Nicole's generous, but maybe lying. Thank you, Nicole. But would love anybody to throw in who's really made an impact on your life. Hi, Kim. We'll take just a moment to let those come in. Oh, Robin Roberts, yeah, is amazing. Alicia, absolutely. Oh my gosh, Kathy. Oh, I love seeing Kathy's name. Please feel free to keep entering those. I think it's such an important way to really honor all of these individuals as we talk about where we are today in advocacy, and then the future that we're going to be a part of creating in tangible and meaningful ways. Boy, it's emotional. All right. Well, thank you. Without any further ado, I am deeply honored to introduce Dr. Rachel Giles for her conversation with us. Rachel and I haven't known each other as long as I have some of the other advocates, but Rachel, hearing your story and then learning about your work and what you're doing in Europe and globally will be such an important conversation for us in this exchange. So everybody, please help me welcome Rachel.
Thanks so much, Dave. Really appreciate it. It's an honor to be here. It's been great. And I wanted to talk to you guys today a little bit about our experience with the International Kidney Cancer Coalition, which is what I founded in 2009. It started, and we've been building it up since then. And I'm happy to talk to you about this, and feel free to enter questions if you want to. And it's nice to see Kathy Traz here too. So I can see the questions, so I'm happy to answer them if you pull them up. I'm going to share my screen because I do have a PowerPoint presentation, but like I said, feel free to jump in if there's questions. Okay, so I'd like to talk about how you can look at other horizons and learn from each other. And I think that we have some experience in Europe working together in a different way than you do in the States or in North America in general. And maybe there's some lessons that can be learned and, duplicated where necessary, or, modified to meet your needs. So I'll talk first, just introduce my organization. It's called the International Kidney Cancer Coalition, or the IKCC. We are, in fact, a global umbrella organization. I don't know if you can see my cursor, but I'm trying to use it as a pointer here. It's a global umbrella organization, and we consist of 46, mostly national organizations, but in the United States, for example, there are several different kidney cancer organizations, and as far as I know, they are all affiliates of the International Kidney Cancer Coalition. Collectively, we reach over 1.2 million kidney cancer patients, but we try and fill the gaps where national organizations are unable to approach, and I'll give some examples of how that works. So when I got into patient advocacy, which was in 2008 after a cancer diagnosis myself, and working with being aware of the problems that families experienced with dealing with cancer, and seeing my own partner struggle with the diagnosis and the treatment, and figuring out all the information that suddenly he had to learn. He's not from a medical background, unlike me, so for him it was a real struggle. He's a mathematician, and this was something that I realized, that there's a lot more to advocacy than we give credit for. And I think that this is the common perception of what patient organizations are. It's just a place where people maybe come together and talk about their problems and seek help and advice from other people, and that's very true. And I think that this is where a lot of the incubators start for good advocacy as well, because they recognize a genuine need and they're filling it. However, they have sort of an idea in the society. A lot of people don't understand what or how patient organizations actually operate, or what their point is. So I just want to kind of talk about that kind of problem that we experience. So I think today you will all recognize this, is that today's reality of patient advocacy is something completely different. Of course, we provide patient support. Virtually all of us do, in some form or another. But they're also really growing into professional societies and organs, which shape health and regulatory policy. And I think that this role is growing rapidly, and patient organizations are needing to adapt to meet those needs as well. And to various extents, many of these organizations also support and shape research. Some of them more than others. Some of them are exclusively directed at research, but most of them to some extent are involved in some flavor of research. But there's additional levels on top of that. In Europe, we tend to see that there's actually 3 horizontal, the 3 I just mentioned, but there's also 3 horizontal as well, levels. And that is, of course, the local national levels. And that's something that I think most of you here are familiar with. And that makes a lot of sense. It fills an immediate local need. But in Europe, we also have a European level where everyone gets together, and I'll talk about that in quite a bit, actually, in different frameworks and systems and research collaborations, but also we access systems, and we have funding from the European Union as well, and I'll talk about that as well. In addition, there's global organizations, and the IKCC that I represent is one of those. So we are European-based. I'm in Amsterdam. I'm talking to you from outside. I'm just near a canal here. It's a beautiful evening here in Amsterdam, the Netherlands. But many of us are based in Europe, but we run actually global coalitions in that case. All right, so at least in Europe, a lot of us, and I'm sure in North America too, and personally I took a lot of inspiration growing up. I grew up in the San Francisco Bay Area, and I was very much aware of the HIV/AIDS activism that was occurring during my younger years. And it really was an inspiration for me that when I did choose to go into patient advocacy, to look at how much they were able to actually change the medical approaches just through speaking out and organizing and being incredibly fantastic patient advocates that I think we can all love and respect. There's so much to learn from them. And I think that these precedents are really important to learn from. And it's a pity there's not a better history lesson on patient advocacy, because I think we could all avoid making some of the same mistakes if we just learned from each other a bit better. Now, in Europe, just specifically where I am, there are substantial obstacles in the EAU that aren't as much present, aren't quite as prevalent in the US as they are here. So for one, we have 24 official languages in Europe and 60 minority languages, which are substantial. They're not minor languages in the sense that no one speaks them, that they're just the ones, the languages that the EU did not choose to take forward, because you really do have to take, you have to make choices at a certain point. We have a 512 million population, so 500 million people. And we have over 27 different healthcare systems. So when you're talking about patient advocacy European-wide, these are substantial problems. Here, this is a bit of a bragging slide here showing that the average Europeans speak, so in the Netherlands where I am, the average Dutch person speaks 3.2 languages fluently. And the only country that speaks it more is Luxembourg, but that's because they're tiny and they're shoved between every other country. But we do speak a lot of languages each, and my kids have to study 6 languages in high school. So it gives you an idea that we just have a different mindset in culturalism, and also the way you go forward with dealing with different societies and cultures. There's a little bit more awareness here in my feeling. I've been on both sides of the puddle, so I think I can compare them fairly directly. So the European patient advocacy community is largely because it's somewhat older than that in North America, but also because it's publicly funded by the EU. It has a very tight structure. And I think that that's something that the North American system could learn from a bit. And it's publicly funded, meaning it's from the EU. So all of these organizations I'm listed here are EU funded. So this is the European Patient Federation. That contains all patients. We also have EURORDIS, which is rare diseases, and that covers rare diseases plus rare cancers. We have the ECPC, this is a Cancer Patient Coalition Federation. And we have WeCan, which is an EU project funded by the EU, which really is aimed at sort of improving the advocacy strategies and professionality of cancer organizations in Europe. So this is something that I think is unique, that you don't quite have in the States, this level of solid funding and infrastructure that's provided by the EU. So just this is an example, and I don't know if I can even see it, but the IKCC is here in this light blue text. But there are disease-specific patient advocacy networks, and we fall under this rare cancers and rare diseases kind of area of things here in the light blue. But there's many of them. So these European umbrella organizations, they all have pretty much the same capacity, and they have some key activities that definitely overlap. And the great thing is we're given a lot of opportunities to exchange ideas with each other and also change tools and events and so forth as well. So there's plenty of opportunities for that exchange, and I'll talk about that in a minute. But virtually all of them develop patient information that's accurate, medically reviewed, and sometimes this is a domain of a national organization, because of course that's convenient if it's in a local language as well. Sharing best practices and facilitating network, they all do this. They provide a knowledge base and sharing educational and research resources. The vast majority do this as well. Advocacy resources and toolkits, that's growing more and more, because we notice that if you have a toolkit ready to go, most people will pick it up and use it. Involvement in research, regulatory projects, guideline or clinical practice developments. This is really varies from one organization to the other. Some don't do it at all. Some do it a lot. There's not a lot of middle ground. I think it's either it's more black and white, polarized. There's a global and regional surveys. I'd say the vast majority of people understand that gathering the data from your patient base is actually a currency. It's a way to present the data in an evidence-based advocacy approach. It's very useful. Healthcare professional education programs. Not very many of them do this, but it's actually quite successful when people do undertake this. And how do we actually get our healthcare providers to learn more about advocacy and more about their patients? And raising public campaigns, a lot of them do this. So those are include things like national awareness days, cancer days, and so forth. Those are fairly common. So my organization, we do one thing on top of those activities that's quite unique to our organization. As far as I know, no one else does this. is we run an annual meeting, not only for our patient advocacy affiliate groups, but for example, when we held it in Portugal last time, we also organized a local professional meeting as well. So in this case, all the investigators and treaters, practitioners treating kidney cancer were invited for a day conference. We held a professional local organization day next door physically to the patient advocacy meeting. And we also had many different overlapping sessions. And the point of this interaction was to expose the healthcare providers to patient advocates and advocacy and the value and professionalism that they do this. So we consider this a very important kind of way to sort of desensitize healthcare professionals to the idea of not working with patient advocates, which is something we often encounter. I'm sure you all have too. So this brings me to what we in Europe call evidence-based advocacy. This is the core of most European advocacy groups. It's when you take targeted advocacy for a certain group, you have some really good data to work with, and you package it correctly. Evidence-based advocacy is the best way to go forward, in our opinion. You can work with researchers, professionals, professional societies, your patients. You're doing everything the right way. That includes all the surveys you do. Those are all evidence-based advocacy. You're making your policy decisions based on actual data instead of just opinions. And those are important things to move forward, but this is a mantra in Europe among the organizations. I don't know to what extent you're exposed to this in North America. So there's been some work done by European groups, and this is sort of the consensus statement, is that we think that, and this has been published, that the patient involvement should be in clinical trials and practice, should really be held at every single level of that development. And we describe in great detail in this paper exactly how that should look like and what the demands are and how that will benefit the overall outcome and, more importantly, dissemination of the results of a certain trial. Because I think that's in everyone's best interest, is to get the research questions right, to make sure that the end product lands in the right hands at the end. So this is a way that we work with industry, but we work with the professional societies, we work with the researchers to make sure that we get everything all on one board at the first time, instead of having to go back and say, no, we thought that this control arm was just completely absurd. We'd rather not complain, we'd rather be part of the process. So the expert advocates, the question was, how do you grow them? Because all of this evidence-based advocacy does require a level of expertise. You have to have people that are, fairly well educated in the processes involved. They're able to read a research paper, they're able to understand a clinical trial, that they're able to ask the right questions, that they're not shy about it. Well, there's been a large investment, again, through the EU, something called UPADI, and this is a 14-month expert training course. It is not for the faint-hearted. It is a big commitment for patient advocates, and it teaches you everything about research and development, and there's been so far 98 graduates from 58 different disease areas. This is funded by the EU, like I said. There's no cost for the individuals involved. And there's been 500,000 individual users of the UPADI toolbox that's been developed. I use it all the time. It's a great thing. They work with all levels of development of medicines, and they train the patients in how to function best in, for example, health technology assessments and so forth, which is often something that people have never heard of. Yet their experience is so valuable moving forward, and it's essential that they're able to communicate their experience in an effective and research-minded, evidence-based manner. I wanted to pause for a second about we can. We shamelessly stole Obama's motto here. And this is an informal work group. Again, it's EU funded. It's a think tank of leaders from 20 pan-European cancer patient umbrella organizations, including the IKCC, the one I'm involved in. And this is really a driver of policy and also sort of putting down the laws. So we're developing tools within WeCan that no other groups are able to prepare. For example, we've worked with various pharma companies to come up with reasonable agreements on the interaction of patient advocates with industry. So if a certain company comes to me and says, could you please speak at my meeting? Could you please be on our advisory board? Usually I would get these contracts that were completely absurd, 50 pages long. I mean, maybe I'm exaggerating, but not by much. And completely difficult to understand. And I'd have to send them to a lawyer to actually say, can I sign this? I don't even know. This is not what I'm trained in, and it's not something I want to be trained in, frankly. So we came up with a very simple, straightforward agreement plan. that talks about costs, that talks about involvement, it talks about what the expectations are in simple language, and several different pharmaceutical companies agree to this, and it's all been signed, and that's ready to go, downloadable from their website. And virtually all the companies we've worked with in the past have agreed to use this contract going forward. So that is an example of a very simple, someone had to hammer it out with a lawyer and a bunch of pharmaceutical companies, and we can took that on. What the fair market value project is. So what is a patient advocate is steadily more seen as an expert, and that expertise is something that has value, and there should be a fair value market attached to that as well. So they're negotiating those. There's a coordinated approach with the education of advocates. So we're making sure that there's quality behind the education of these advocates, and as well as a contribution to research and how participants participate in research. That's an important way to have a quality stamp. There's also, for the record, because this is partly discussing about COVID-19, the pandemic, there's a reliable webpage there with toolkits as well available to cancer organizations with regard to how you communicate and how you educate your advocates and volunteers with regard to COVID-19. So I'm going on and on, but I'm just going to mention two more notable things. One is ESMO. So that is our equivalent of ASCO. It's the European Society for Medical Oncology. They have they've been ahead of the ball game for a long time with regard to patient advocacy, and they've had a patient advocacy track in their meetings. Patient advocates are seen as full members, as experts. They're expected to serve on committees. They work as any other ESMO member in that society, and they have their own talks and their own poster sessions, and patients are encouraged to present evidence-based advocacy elements. And this has been, I myself, I was the first, I think, patient advocate to ever chair a meeting at ESMO. I've been on their organization committees, their scientific programming committees. They're extremely good at putting forward patient advocates for all of these levels of discussion. Quite admirable and something to definitely emanate. In addition, sort of a spin-off of ESMO is the European, what's it called? Not society. It's an educational program called ESO, and it's a school of oncology, that's it. They're based in Milan, Italy, and they have training courses for advocates that last about 4 days. They're held beautifully in the mountains of Italy, and they are really quite excellent. They're fantastic ways to not only meet other advocates, but also just learn the basics of advocacy. So if there are patients that are interested in developing their skills in this regard, these are all fantastic tools, and they're open to everyone, really. So talking about what there are, and as far as European umbrellas, I mentioned some of them before. ESMO has been fantastic at supporting patient advocacy and bringing them together. But we also have the ECHO, which is also a fantastic European organization for patient organizations. The EORTC is actually our sort of body that works with clinical trials. They've also been very good at bringing patient representation into clinical trial development in a very impressive way. We have other professional societies that are very active in that. We work a lot with the Rare Cancers Europe as a rare cancer, kidney cancer, but there are just so many options out there. It's something that I think we don't have elsewhere in the world, and Europe has been quite forward-thinking in this respect. Interestingly enough, this is something that's still fairly new, but developing rapidly. There's the public-private partnerships and industry initiatives are picking up rapidly here, and they are bringing in patient representation and expertise at many levels. And just a few examples I wanted to name quickly is you've got the UPADI consortium, which coordinates a lot of things, but it's a European project entirely funded by the EU money. These are all Horizon 2020 European funded projects. In fact, you've got the Paradigm, which is a private partnership as well. There's, I think I mentioned these all actually previously. The European Federation of Patients think tank is very important. And of course, there are a lot of patient involvement investigator meetings, trial review. I sit personally on the steering committee of a couple trials. So those are things that are definitely happening quickly, rapidly evolving, fantastic developments, and I think only natural in the evolution of patient advocacy, to be honest. Slowly but surely, we're becoming equal partners, valued partners in these processes. And I think that this is something that cannot be supported enough. I think it's bringing better quality to the products across the board. So I just wanted to turn a little bit here for just a few seconds, a couple slides talking about what happens when global organizations band together. So we've already a global organization representing 1.2 million people, but now we've gotten together since COVID-19 with 8 other global organizations. So everything from breast cancer to lymphoma to bladder cancer to colorectal cancer to brain tumors and so forth. You can read them here. And together we are collectively over 750 organizations and 14 million cancer patients, at least, that we can count. So this is a fairly large thing. We got together, we ran a survey on the organizations to find out how are the organizations dealing with this pandemic. This is a problem that we've seen in our daughter organizations, our affiliate organizations. So we put out this report, we released it last month. And essentially, of 157 organizations took part in the survey. And what happens is that in pre-COVID-19 in December 2019, about roughly it was split into third. A third of the organizations had no paid staff, a third had 5 or less staff members, and only a third had more than 5. But a year later, those organizations with staff, the number fell from about 21.2 full-time equivalent staff to 17.4, which is an 18% drop. The average number of volunteers per organization fell from 369 volunteers per organization to 107. That's a 70% drop. The majority are either fully or mainly home-based since the beginning of the pandemic. That makes sense. 2 organizations, unfortunately, have had to close permanently, and another 13 have had to pause their services as a result of the pandemic. So the changes to services were actually not too surprising, but just notably was obviously suddenly everyone had to provide the majority had to provide information about COVID-19 for patients that had not been there previously. So this was not something you could just repurpose from other things. You had to actually find the evidence there. Most of them, of course, naturally stopped having face-to-face support services. That's natural. But what is really important here is that pretty much all of the organizations had to alter all of their services. And that required a huge amount of dynamic understanding of things, adaptation, but also the ability to, be creative, think about how you can approach things. It takes resources, that takes people. And yet we saw in the previous slide, they had fewer people as a result of the pandemic at their service. So again, not too surprisingly, there was a lot of questions with regard to treatment that include didn't mean to do that. About 8 in 10 of the organizations surveyed actually do run a helpline or take email inquiries. And of those, over half saw an increase in the number of calls. In fact, those that did see an increase did actually report nearly half as many contact points as well. So this means that the request for help and paramedical services to the patient organizations surveyed, 157 of them globally, resulted in a huge amount of more work, but they had fewer resources and fewer staff to deal with it. Just one quick note, the impact on patients within this was quite remarkable. If you just look at the yellow bar here, or orangish kind of bar here, you can see that that's worse than ever. And that was true that the stress, anxiety, and depression in patients was worse than ever as a result of the pandemic. Increased isolation for all patients in general was worse than ever, and the financial hardship was worse than ever. So these are substantial impacts on patients. We know this to be the case, but the data really speaks for itself. So the predictions for 2021, can we weather this storm? Well, 79% of those who raised funds were predicting a fall in the income over the year, and an average expected fall was about 50%. And only 5% of the organizations surveyed did not expect their funds to fall. So if that's the case, then about 2/3 of the experienced a falling income with an average fall of nearly 50%. And 21 organizations from 18 different countries experienced falls of more than 50%. So of those surveyed, the ovarian and the pancreatic groups seem to have been hit the hardest. We're not sure why that is. Proportion of organizations with falls of income more than 50% by tumor type. So here you can see ovarian and the pancreas coming back together, but many of them showed some kind of problem. It didn't seem to affect any single form of fundraising. All of them seem to be affected fairly equally. And the income predictions for 2021 were not good. About 10% of the organizations said that their viability was quite threatened. Another third said their future viability was uncertain. And basically the take-home message that we really want to share with you is that cancer care cannot and will not wait for COVID-19 to pass, and if it ever will. You all provide actual essential services, and it's important that they're recognized. And I'd like to hope that the European example might be something to work towards. Although it's not perfect, it seems to be more integrated, and it does have central funding, which allows its security and smooth operations by and large. Patient organizations, they really fill important gaps left by health services, and those are paramedical mostly in nature, but they vary. They can also be funding research and so forth. Patient organizations, simply, you're never alone, and other organizations will always champion your cause. Continue asking for funds. Be creative with how you do it. It's going to have to be different with this pandemic time. Network and collaborate as much as you can and share resources where possible. Take the positives forward. That's all common sense stuff. But mostly, I think people do forget that you simply cannot look after your fellow organizations if you're not taking care of yourself. So be sure to shore up your own organizations and yourselves as well, because it's really hard work ahead. And it's going to be a great time after the pandemic, and hopefully there will be some really good things that we can take forward. But right now, we're just trying to get through it and survive. So thank you very much.